I want to really thank you all, both as a parent and as a clinician researcher. So I am a parent of a child with AFM, and I'll get into that in a little bit. And I want to thank all of the other parents, our extended Blue family, the parent Facebook page, the sRNA, which is has provided an unbelievable amount of support, and then all the parents who've been participating in advocacy, both in formal channels and in formal and informal channels. I also want to thank you as a clinician researcher. So here's my disclosure. I'm an MS adult neurologist. I'm not a pediatric neurologist, and I'm not an AFM expert. And as a clinician researcher, I know just how hard each of you clinicians and scientists has worked on behalf of these children and young adults with AFM. And I know that a lot of this work has been out of your hearts, out of your dedication as clinicians, and hasn't necessarily been reimbursed or supported to the level that other types of work have been. So I really want to thank Carlos and everybody who's putting on this fantastic series on behalf of us parents as well. I know how hard you've worked and how appreciated it is. So, and here, you know, sometimes as women, as scientists, we feel like imposters. I get to be an imposter in both ways, both kind of a neurologist, you know, imposter as a parent, and also as a parent impostering as a researcher. So just want to acknowledge that and say that what I'm going to talk about today is really some of the unmet needs that we recognized, you know, as my child and I were navigating this condition in our family, and recognizing that there are some pieces that I was hearing as a parent that may be useful to the clinical community. And so that's sort of the role that I am hoping to fill today. And I'll talk a little bit about the diagnosis and patient treatment, but also about early recovery and then long-term recovery and sequelae. And hopefully that will dovetail nicely with the rest of the talks today. And so here are just some of the pieces that we put together to kind of try to bring this parental perspective to the fore and try to meet some of the unmet sort of research gaps, and particularly the pediatric neurology paper that just came out this year. And so the methods for that pediatric neurology paper, we actually did a posting to the Facebook AFM parents group with a survey, Qualtrics survey link, and we did the posting in 2017 and then in 2018 as well. And there were 167 discrete questionnaire responses that were considered complete. There was some overlapping responses that were sort of removed. And so at the time, the group had about 500 members. Now it has over 800 members, just reflecting the increase in prevalence. And the respondents were mostly the mother, sometimes the father, and then other grandparents, uncles, aunts, etc. And we performed mixed qualitative, quantitative methods, so both to look at some numbers and also to look at the qualitative responses. And this did have an IRB exempt status from the UCSF IRB. And so this this figure kind of shows you the spread of age at symptom onset. And so in general, the children affected here were a little younger than what had been described by the CDC. And they were mostly kindergartners, preschoolers. The third panel on the top shows you whether they were first a child, not the first child or the only child in the family. And then you can see sort of the counts of sort of reported onset of AFM, and you can see sort of the 2014, 2016, 2018 spikes that corresponds with the epidemiology. And you can also see where the children came from. Of note, very few respondents were from Colorado, which is interesting because the Colorado cluster had been so nicely reported by the Colorado group. And so just a few more details. So mean duration since AFM onset was 2.5 years. So we had some nice outcomes that were beyond the sort of typical 1-year outcome. And 68.6% of all the children were actually at least 6 months from onset. And again, mostly preschoolers, kindergartners, and the median age at onset was 5 years. 80% were Caucasian, and 61 almost percent were male. And just the early clinical features, which matches a lot of what's been described already, is the mean duration inpatient was 49 days. At their nadir, over 2/3 of children had one of or several of walking impairment, leg weakness, arm weakness, sitting impairment, and pain. 40% had quadriplegia. And of non-motor symptoms, there were several actually: sensory, hypertension, and almost 1/3 of the children. A quarter underwent a tracheostomy with a mean duration of about 15 months. So the first unmet need are really challenges to prompt diagnosis. And this certainly my child Luca's story is the classic narrative arc. He turned 4 and was entirely healthy, very well. 2 weeks later, the whole family came down with a febrile illness. We all recovered. And 2 weeks after that, Luca came down with some respiratory difficulties, what was interpreted as asthma, and telling me he was weak, unable to lift his arm to drink. I took him to his pediatrician, who told me that his weakness, when I told her he said he was weak, was due to his fever, and we were sent home with a nebulizer. My story is a little different from others in that I did have really fantastic access to an expert pediatric neurologist at Children's Hospital in Boston who, when I sent her the video of my son, urged us to come right in. And we had the, good fortune of being insured and well connected. But even then, we had some of these same challenges as everybody else, even despite our privileges. And so over 60% of respondents did report challenges to prompt diagnosis, with really an unknown impact on their child's prognosis, of course. It's not clear that the earlier diagnosis might have made a difference, but it certainly did set up really sort of a difficult relationship between some parents and the healthcare system. Reassuringly, the challenges actually decreased between the children whose onset was 2014 to 2016 and thereafter. And this is a significant decrease, suggesting that all of the dissemination efforts have actually really made a difference. The types of challenges were just a wrong diagnosis, repeated visits to the doctor before the gravity was recognized, and often a diagnosis of a functional disorder, conversion, psychosomatic, etc. There was commonly a lack of a neurological evaluation by the initial clinician, even when the presenting complaint was weakness. Guarding from pain may have masked some of that. And even when there was a neurological syndrome recognized, unfamiliarity with AFM kind of made things worse. Then when we were discharged from that inpatient rehab, there was a real unmet need in terms of navigating rehabilitation trade-offs. So this is Luca here, and what we found is that there were very few pediatric personnel who knew how to really rehabilitate the condition. And so, for instance, we saw top experts to see if his shoulder, which was completely plegic, should have a nerve transfer, and it was not recommended. There was a concern about post-polio syndrome occurring and sort of being even worse after a nerve transfer. Scoliosis, so initially he was braced, and then there was a decision to just continue that to allow the core strength to return. The shoulder weakness, he was put in a wrap, and eventually that was discontinued because we realized he needed to encourage the functional recovery in the upper limb. Neck flexor weakness was not recognized at all, even though he had terrible neck flexor weakness, and we ended up doing sort of self-bracing. And finally, we maxed out of rehabilitation very rapidly. And these are things that, many of the parents report. And then what about the more long-term outcomes? And so this is a bit of a bleak picture that was in the New England Journal story, but that is not an entirely bleak outlook here. And so this is a table from our pediatric neurology paper. At a mean of 2.5 years post-onset, there were persistent deficits. Greater than 50% of children had weakness in either arm, and or weakness in either leg and or walking impairment and or fatigue. And of note, parents were starting to see legs and arms of different lengths, osteoporosis, and joint laxity, among other concerns. In the parents whose children were more than 2 years out, you can see that in most cases, deficits continued. They reported that deficits continued to limit their child's ability to do what they would like, and the child's ability to participate in daily activities had changed dramatically. Against that pretty bleak backdrop, we also note ongoing recovery. For children who are 6 months plus out from onset, 80% reported to show ongoing, even if subtle, improvements in function. New regions were activated, increased strength or bulk of recovering muscles, range of motion, balance. Half of the children could participate in some form of athletics. Many of the children who were ventilator dependent had come off, and over 20% had actually undergone a nerve transfer surgery, suggesting dissemination also of the surgery is happening nicely. But there is a mismatch between the potential for long-term gains and access to ongoing therapy. And so rehabilitation has been really perceived by parents as being effective, but access is limited by reimbursement. And so there's a need for samples of letters to insurers, need for documentation of long-term gains. The studies that are now coming out about long-term outcomes are critical here to help parents with insurers. Access to specialists, and here telemedicine has been sort of revolutionized with the COVID-19 pandemic, and this is an area of potential growth. Access to facilities, and then rehabilitation psychology. It's very hard to keep children motivated to do rehabilitation week after week, month after month, year after year, especially when the gains are ongoing but slow. And dissemination of information about the successes to local clinicians is key. Again, clear messaging and dissemination is a major unmet need, and I can tell you that daily parents post on the parent site about electrical stimulation, bracing, surgical options, what to do with bones and stem cells daily, and clear messaging here will be really, really helpful to help parents to reduce kind of the uncertainty and help propel to action. Finally, the emotional impact has only sort of begun to be explored. This is my son, Luca, and his brother. So in terms of the impact on the child, other parents have said nothing is the same after this injury. Loss of the normal self, grief for the normal self, the self-identity as being disabled is a huge transition. Reassuringly, academic performance was reported to be fairly intact, but there are behavioral sequelae, anxiety, emotional outbursts, socialization with peers is hugely affected, and the role in the family and with siblings. Often the sibling is forgotten. They're the child who has to sort of go with their affected sibling day in and day out to rehabilitation, the one who's left at home when the parents are in the hospital with the sick child. And long-term, the impact on them as well must be considered and acknowledged. Impact on parents. A lot of uncertainty about cause choices. There are uninformed clinicians, how to navigate them, what are the long-term outcomes one can expect. There's a daily worry about the child's safety with each infection or setback. There's a worry, and also with the summer dread. We dread, again, to see what happens this summer. The parents become caregivers, and many had to change their employment. Many had to go to part-time, and some even had to quit work to handle this. If there is time, I'll ask Carlos if I can show a brief video, but I just want to summarize our message here. Awareness efforts have improved our early experiences with diagnosis and care, and our trust in the organizations with the CDC making this a priority, and the associations that have emerged. Ongoing recovery is occurring. There is a need for expanded access to specialized care, for clear messaging around rehabilitation procedures and surgical options, and also the long-term emotional impact. I will just zip out of this for a moment and just show you, if I can, and just show you Luca today. This was just a video I took a few moments ago. And again, this is Luca, who was paralyzed from head to toe, from pons to cauda, diplopia, facial paralysis, neck, arms, torso, and legs. And here he is this morning. So in the video. You can see the shorter right arm, it's weaker. You can see the shorter left leg, it's weaker, it's plegic, but the functional recovery is immense, and the impact on the child of ongoing hope and ongoing options is immense as well. So I will go back to the PowerPoint. And I want to thank you for your attention, thank the organizers for inviting me to speak, thank the other parents and all of you clinicians and scientists who are doing so much for our children and for this condition. And I'd like to introduce our next speaker, who's Dr. Andrea Bauer. She's an assistant professor of orthopedic surgery and a pediatric hand and upper extremity specialist at Boston Children's Hospital and Harvard Medical School. And she'll be speaking about late tendon transfers in the upper extremity.